Good afternoon, everyone, and welcome to this session on shedding light on ARDS. I'm Dr. Michelle Ngong from New York, and sitting next to me is the esteemed Dr. Taylor Thompson from Boston and Mass General Hospital. So it gives us great pleasure to welcome you today to our session, and I'm looking forward to hearing from our various speakers today.
Thank you, Michelle. Our first speaker is Alex Demoule from Paris, who will talk to us about ARDS in immunocompromised hosts.
Thank you very much. Good afternoon. Thanks for the invitation to give this talk on ARDS in immunocompromised patients. And it's very difficult to answer the question that was asked, actually, which is it a specific entity or not? And I will show you that in some respects, this is a specific entity, but in other respects, this ARDS has to be cared such as any other ARDS. Here are my disclosures. So, acute respiratory failure is clearly the leading cause of ICU admission in immunocompromised patients, and among around 35% of patients admitted to the ICU for an acute respiratory failure will develop an ARDS. And this ARDS has specific features. First, there is neutropenia that we need to take into account. There is opportunistic infections, and especially fungal infections, that we also need to consider. And there's also the group of, let's say, secondary ARDS with an unknown diagnosis due to lung toxicity, but also possibly due to infiltration by malignant cells. And those are the specificity of these ARDS. So, are those ARDS in immunocompromised patients quite different from ARDS in immunocompetent patients? Yes, they are. There's a lot of differences. So these are data from the Cortegianis group from the LungSafe study. And as you can see, there's many differences between immunocompromised and not immunocompromised patients. Immunocompromised patients are more frequently women. They're younger, and their body mass index is lower. But they have less comorbidities, such as COPD, diabetes, or heart failure. In terms of ARDS risk factors, the two groups are also quite different. As you can see, immunocompromised patients have more frequently pneumonia, pulmonary vasculitis, or a non-cardiogenic shock. And on the contrary, you can see that non-immunocompromised patients are more likely have pulmonary contusion or trauma or aspiration of gastric content or pancreatitis. So you see that the profile of the patients is different, but also that the risk factors for ARDS are different. But what is also different is mortality. As you can see here, the mortality of the two groups is quite different, and the mortality of immunocompromised patients is much higher than the mortality of the immunocompetent patients. I would say that the good news is that this mortality has dramatically decreased over years. During the late 90s, the mortality of immunocompromised patient with ARDS was intubated, was 90%. And you see that years after years, it decreased. These are data from the Eli Azoulay group. And you see that at the mid of like 2010, it was 50%. And right now it's more 40%, 40 to 60%, so 40, 50%. So it's improving because we are improving the way we take care of these patients. And I think that's important information. So what are the risk factors for death in immunocompromised patients? Well, they're, of course, a little bit different from those that we observe in immunocompetent patients. You see that patient with solid tumor is kind of protective, and that, on the contrary, immunocompromised patients with ARDS who have allogenic bone marrow transplantation are more likely to die. Of course, the severity is a risk factor for death. And you see that primary ARDS seems to be protective. On the contrary, and this is extremely important, invasive fungal infection is independently associated with mortality. I think this is very important because it reminds us that when we are treating an immunocompromised patient with an ARDS, we should always think about fungal infection, and we should track fungal infection, and in some case, we should treat fungal infection waiting for, without an evidence of fungal infection, I mean. NIV failure, of course, is a risk factor for mortality, and the severity of ARDS is a risk factor for mortality. So, another question is, in immunocompromised patients, is lung protective ventilation an important challenge, an important issue? Should we care about protective ventilation in those immunocompromised patients as we care about protective ventilation in immunocompetent patients? And we know that in immunocompetent patients, the protective, to deliver a protective ventilation is extremely important in terms of prognosis. And from this data from the LungSafe study, we see that there is a direct relationship between the mortality, the hospital mortality, and either plateau pressure or driving pressure, with a cutoff for plateau pressure that is around 28-30, and for driving pressure, which is between 10 and 15, probably 13-14. So the question is this the lung protective ventilation and the characteristics of lung mechanics of the respiratory system also important in immunocompromised patients? So we investigated this issue a couple of years ago, 2 years ago, and using the data from the Ephraim observational study led by the group of Eli Azoulay, we focused on patients with ARDS, and especially on those with information on lung protective ventilation and respiratory mechanics. And in these patients, we measured compliance, plateau pressure, and driving pressure. So the whole cohort was 1,600 patients. Among them, there were a little bit more than 800 patients intubated for ARDS, and plateau pressure was missing in some patients, and we had, by the end, approximately 500 patients immunocompromised with an ARDS, and in whom we had all the information on respiratory mechanics like driving pressure, plateau pressure, and compliance. So ARDS severity was like this: 21% mild ARDS, 47% moderate ARDS, and 32% severe ARDS. And mortality was 54%, which is quite consistent with the recent data from the literature in this population. So it's a higher mortality than in immunocompetent patients, obviously. So first information, so we compared PEEP and tidal volume in survivors and non-survivors, and we saw that PEEP was a little bit lower in survivors, which makes sense because people, as I heard, in patients with the most severe ARDS, so who were more likely to die. Tidal volume was not different between the two groups, but you can see, and this is good news, that the median value of tidal volume was very close to what is recommended. So those patients received actually quite protective ventilation. And plateau pressure was higher in patients who died, as was driving pressure. And you see that it was also very close to what is recommended in major guidelines on ARDS. But it looks like patients at risk of dying who died had more altered compliance and then higher plateau pressure and driving pressure. So we performed multivariate analysis to isolate the factors that could be independently related to mortality in this population. And we observed that vasopressors and renal replacement therapy were associated with higher mortality. Fungal infection was, it doesn't, it breaks the line, but it's still a higher odds ratio. And driving pressure was also associated with higher mortality, such as we observe in immunocompetent patients. Then we replaced driving pressure by plateau pressure, and we observe exactly the same thing. And we replaced plateau pressure by compliance, and we observe the same phenomenon, like the lower the compliance, the higher mortality. And we see here that patient with low compliance, again, and those with high plateau pressure or high driving pressure were more likely to die, which really points that the protective ventilation is extremely important also in immunocompromised patients. So to conclude, and these are my take-home messages, I would say that ARDS in immunocompromised patients has definitely some specificities. First, there are features that are specific to these patients. Unknown diagnosis, which is a real issue. When we manage an immunocompromised patient with ARDS, we should make a diagnosis, because when we don't make a diagnosis, the patient is more likely to die. So we should do everything we can to make diagnosis. And fungal infections are a real issue. We should always consider fungal infection, and we should always consider the treatment to treat fungal infections. Definitely we need future research to improve the diagnosis and the management of this patient, and especially new techniques to make more quickly the diagnosis of fungal infections. And last, the respiratory mechanics is strongly associated with the prognosis, such as we observe in immunocompetent patients, and that therefore it's extremely important in immunocompromised patients to give a protective ventilation, such as we give in immunocompetent patients. This is not different. Thank you very much for your attention.
Thank you very much, Alex, and I'll second your concluding comments about the importance of establishing an etiologic diagnosis. Reminds us that ARDS is a syndrome, not a diagnosis per se. We have a minute for questions. Please introduce yourself and where you live.
I'm Özkan from Istanbul. I want to ask about the opportunistic infections in this kind of patients, like pneumocystis carini infection and CMV infections. Do you check them, and
Yes,
how often do you see?
Yes, we always check them. Depending on the underlying disease, the patient may receive a prophylactic treatment of those infections, but we always check those infections, and we see them quite often.
No other questions. Alex, well done. Thank you so much.
So our next speaker is Dr. Adrienne Randolph from Boston, who will be speaking to us today about the pediatric ARDS is also different. Thank you, Dr. Randolph.
Thank you. All right. So I have no relevant disclosures. So I'm going to talk a little bit about first the diagnostic criteria differences between adults and children for ARDS, and then epidemiologic differences. I'll then talk about management strategies very briefly, because I can't cover everything in detail, and then about prevention. So first, I just want to say that the Pediatric Acute Lung Injury and Sepsis Investigators Network, a lot of the data that I'm presenting came from this network. There's about 90 different sites in the US and Canada involved. And and they're ongoing. They're actually meeting now at the same time as this meeting. So one of the things that the Policing Network did, but also internationally, this was an international consensus conference, the POLIC Acute Lung Injury, Pediatric Acute Lung Injury Consensus Conference. You can see here the different diagnostic criteria for ARDS. The Berlin criteria were in 2012. The POLIC were 2015. And then in the first definition for neonates, not including premature, but neonatal ARDS was the Montreux definition, and that was a different consensus conference in 2017. So now from that POLIC definition, it's called PARDS, or pediatric ARDS. And you can't see this very easily because it's small, but I'm just showing what's different and what's the same. So the gray is the same, the origin of edema, excluding left atrial hypertension in neonates and echocardiograms required because they often have congenital heart disease. Chest imaging, though, is what's really different, and unilateral infiltrates is what's the big difference between POLIC allows unilateral infiltrates, and bilateral opacities is the Berlin definition and the Montreux definition. The other things that are different are that because we frequently don't put arterial lines in if a patient is moderately hypoxic, and we use the saturation index, the oxygen saturation index, or the SF ratio, we have criteria for that, where the Berlin is the PF ratio and the Montreux is the oxygen saturation index only. Now, why did we decide on unilateral infiltrates? And not everybody agreed on that in the consensus meeting, but looking at these two x-rays, which patient has ARDS? You know, it's very hard to tell, but on the right is pulmonary edema from cardiac failure, and on the left is ARDS from influenza pneumonia. And, you know, and if you do studies looking at agreement amongst ARDS experts on chest radiograph interpretation, it's fairly low. So they decided unilateral infiltrates was sufficient in the consensus conference. To validate these definitions, a study that was a point prevalence study, 10 weeks, 5 days of each week over a year and a half, called PARDY, that was published in Lancet Respiratory Medicine. And this was international, 27 countries, including some low middle income countries. And there were 744 patients. Overall, the mortality using that POLIC definition was 17%. But if you applied the Berlin criteria to the patient population, the mortality was actually higher using the Berlin criteria. But those patients also had to have blood gases versus just saturation, so they were sort of by nature a bit sicker. So the next thing that happened that just came out February 2023 is this update of the PLEAK guidelines. The PLEAK came out in 2015, and recently a large group of people, including myself, updated the recommendations and the criteria for ARDS. There weren't that many major changes to the criteria, but we added possible PARDS and at risk for PARDS patient populations to be able to track them epidemiologically. And also, unfortunately, there was only one strong clinical recommendation. Everything else was sort of moderate strength, or this was moderate or higher evidence, and everything else was low amount of evidence, unfortunately, for all the recommendations, or a good clinical practice statement. But the only one that was with moderate evidence was about maintaining PEEP levels using the ARDS network protocol at the lower level or higher. So just to go over some of the studies these are studies that the Plessy network did. We were very into endotracheal surfactant, and we actually did 4 different randomized trials. And the summary is that it does potentially improve oxygenation transiently, but it really didn't improve clinical outcomes. The first trial was promising. It was calfactin, and that's high in surfactant protein B, made from calf lung. But in that trial, that was a positive trial, and mostly in the younger patient population. So then we did a leucinactant trial where we enrolled in Chile and in the US at 26 sites, and decided to focus on children under 2 years using recombinant leucinactant, which is high in surfactant protein B. And that was improved hypoxia, but it didn't move on to a definitive larger study. And then they did a second calfactin trial that was stopped for futility because there wasn't going to be enough, there was no difference in the outcome at 110 patients. And Doug Wilson and Neil Thomas did a lot of this work. High frequency oscillatory ventilation is another thing that we use more frequently in pediatrics than was used in adult medicine. And John Arnold did the first trial in 1994. It was a crossover study, making it a bit hard to interpret, but there was a less supplemental oxygen at 30 days in the high frequency arm. Martha Curley, so these were Boston Children's, these were some of my colleagues there, John Arnold, and then Martha Curley at the time was at Boston Children's. She's a PhD and a critical care nurse specialist who enrolled 102 children, 8% mortality. It was stopped for futility. But now the Plessy network is doing a trial called Prospect that Martha is leading, funded by NIH. And it's a factorial design, outcomes ventilator-free days. The comparator is prone and high-frequency oscillatory ventilation. And prone is 16 hours a day for a maximum of 28 days. And then high-frequency, there's a whole protocol that Martin Niebuhr came up with and uses at his center. And those are the 3 PIs. And it's actually enrolling worldwide. And including in some countries like Thailand, Australia, New Zealand is helping, and they're actually looking for more sites now because enrollment has been not as fast as they wanted. Rescue therapies, however, the PLEAK recommendations are, these are conditional, low certainty of evidence, but the two of the rescue therapies was inhaled nitric oxide. And there's some patients with pulmonary hypertension and severe right ventricular dysfunction that they're recommending it be considered, or maybe as a rescue or a bridge to getting onto ECMO. And then ECMO is considered a rescue therapy that's commonly used in children, although there is low certainty of evidence. The outcomes are pretty good with survival. In our COVID cohort, for example, we have a paper coming out, and its mortality was 26% in the mostly teenagers. So this, just another thing to note in children is fluids. This was the ARDSNet trial. liberal versus conservative, and we did a study getting all their data and converting it to per kilo, fluids per kilo, like we do in children. And this was Stacy Valentine, who was a fellow at the time. And we did this, and this is what shows in children that, you know, we thought that we were doing conservative fluid management, but children are the pink, and they're the most fluid overloaded. So they were the liberal arm plus. And some of that's because the, you know, median age is 5 years in younger children. You have to dilute the drugs into a certain amount of volume. So if you give a dose of vancomycin, it's going to be proportionally a lot more volume per kilo. But just going on to prevention, you know, pneumonia is the most common cause of death in children worldwide. And, you know, if we prevent pneumonia, which is mostly vaccines, you know, we'll prevent a lot of ARDS. And so one of the things our network does is work on prevention. And so we did a vaccine effectiveness study for flu against life-threatening illness, and this was 2019-20, right before the pandemic. It was in clinical infectious disease, showing how effective vaccination would have been if, you know, most likely if these children had actually gotten vaccinated, but most of the kids in the ICU end up not having vaccination, although it's universally recommended for children in the US up to age 17. And then just to note the effect on long-term outcomes. So this was a very intriguing study that just came out and in Lancet on March 7th. And it showed that they followed up people who for like a long 40 years or so, or even longer, this whole birth cohort in the UK. And those who had a lower respiratory tract infection at under age 2 were more likely to die of a respiratory cause early. So, and they controlled for smoking and, you know, all kinds of potential confounders. And those, when it occurred more frequently, which a lot of our patients get multiple infections or they needed inpatient treatment, you know, the risk of dying young from a respiratory cause was even higher. So, you know, following up these patients to look at their long-term outcomes is really important. And so just in summary, you know, PARDS is associated with high morbidity in children. It could have lifetime impacts. The PLEEK definition, really the big difference is the unilateral infiltrates, and preventive interventions may really decrease the frequency and of course improve overall health outcomes. And we basically are recommending what the adult guidelines. Thank you.
So we will have a discussion later, but we do have a little bit of time. So maybe we can take one question or so from the audience. If not, I have one question for you.
Okay.
Yeah. So it's always struck me that ARDS in kids with this big age range is quite heterogeneous, right? A 14-year-old with ARDS looks a lot like an adult ARDS to me and manage. But as little kids may be much different. And given actually some of the data that shows that maybe endotype switches with age, have you ever thought about looking at some of these negative trials in kids with ARDS to see whether or not there might be some differential response based on the age?
Yeah, so the RESTORE trial that Martha Curley led, which was sedation and mechanical ventilator extubation readiness test protocol, that was a cluster randomization negative trial, used Carolyn S Calfee's, hyperinflammatory phenotype, and that's one of the found a difference similar to what she found in statins and some of the other. If the patients had the hyperinflammatory phenotype, there was a positive outcome with doing the extubation readiness testing and having the ventilator protocol. So that was one cohort that they did apply that to.
Fascinating. All right.
I have one quick question. Adrienne, that was terrific. Thank you. The PLEEK made some fine tuning at the last revision. Did they retain the unilateral, Or
Yes.
Yes, they did. Thanks.
They did, yeah. And I apologize, but I have to give another talk, so I won't be there for the
Off you
discussion.
go.
then
Thank you.
We got some questions in, thank you.
Well, thank you, Adrienne. So, our next presentation is from Jesus Villar from Paradise. I mean, Las Palmas, Gran Canaria. It's almost paradise. And Jesus will give us a talk on respiratory subsets, my personal view. Jesus, thank you.
Thank you, thank you. I like to talk, Adrienne, I know Adrienne for many years ago, and I remember in my thesis was a paper, was a time that the ARDS was called the Adult Respiratory Distress Syndrome in children, and that was an oxymoron, and I like that now we recall it acute respiratory distress syndrome. I am a very weird intensivist because I was trained in neonatal, in pediatric, and adult ICUs. And I know very well because I have patients with meningococcal septicemia developing ARDS. And was at the time that we call it adult respiratory distress syndrome in children. Anyway, thank you very much for this invitation to. I recall this talk a personal view, not my personal view, like Jean-Louis Vincent like to talk, but I prefer. I don't have any conflict of interest in relation to this talk, but I would like to start by saying that in the consensus process of the Berlin definition, 518 patients, a lot of patients, 500, were excluded because the value of PEEP was missing or because was below 5 centimeters of water. In fact, in addition to that, in addition to the 500, almost half, more than half of patients had a baseline less than 10 centimeters of water of PEEP, something that in my training, in my unit, was something very hard to believe if you call it ARDS. Anyway, so because of that, the panel of experts of the Berlin definition selected a unique level of PEEP 5 or greater when they describe the definition. So it's very important that you should know this. In addition, there was no standardization of ventilatory setting for measuring the PO2 because they accept any FiO2 under a P5 or more, but to calculate the PF ratio. And in fact, they didn't look into what happened with those patients at the following day, because I knew that many patients, I don't have the percentage because it was not published. Many patients, they don't meet the criteria 24 hours later using the standard intensive care management, okay? So I met Tom Petty. Tom Petty was one of the authors of the 67 description of ARDS published in The Lancet, 1967. And I met him in Toronto in the early 90s, and he told me something similar to what he published 20 years ago when I met him, before I met him. He said a blood gas response to PEEP should be part of the definition of ARDS. And then I took seriously because who in this room believe that a patient with FiO2 of 1, PO2 of 208 and P15 has a mild ARDS? Who believe that a patient with FiO2 0.35%, PO2 69 and P5 has a moderate ARDS? And who believe that a patient on 75 FiO2 with a PO2 74 and PIP6 has a severe ARDS? I hope nobody believe this. But this is the criteria in which patients include patients in randomized controlled trials based on baseline values. So this is why we decided in 2004 to assess the effects of 2 levels of FiO2 and 2 levels of PEEP, FiO2 0.05 or 1, or P5 or PEEP10. Of course, if patients require more, we have certain rules, and everybody who participated in this study that is called the HELP network, did it. And what happened is we did this group of 170 patients, and we divided in 4 subsets depending on the PEEP and the FiO2 at the baseline and 24 hours later. And the best scenario in which patients were different in terms of mortality, in the ICU mortality, was at the following day, at 24 hours after the onset of the diagnosis, with patients. So patients were classified depending on the FiO2 50% or PEEP10. So based on this, we continue doing a validation study. But before that, we received an invitation by Antonio Pesenti in 2010 to write an editorial or a paper in the current opinion on critical care 2010. Then the article was published in 2011. I did it with Bob Kaczmarek, that he died 2 years ago, and Jesus Blanco. And we said in that editorial that it's time to change. This was based on the American and European consensus definition. This is a time to change the ARDS definition. A newer classification system that recognizes different severities of pulmonary function should exist. And then that was based on the result that we had based on this article. We used the 170 patients in the HELP study as a derivation cohort, and then we add 282 patients that we published in intensive care as an incidence of ARDS in Spain, in which we just validate the the ventilatory standard settings at the following day of the onset of diagnosis, in which we used, this is an article, I tell you something, this is an article, and he's about to tell you that, because I don't think Taylor will know this. This is an article took us more than 2 years to publish. We sent it to 6 journals, was reviewed by 16 reviewers during that time, during that process. All the time we are rejected by the reviewers, even though some editors were agree to publish it. We finally published in the Intensive Care Medicine in 2013, was accepted and published ahead of line. But anyway, so we used in that paper almost the same terminology as the Berlin definition, mild, moderate, and severe. I just to tell you that because I have an historical perspective of this. So we continue adding more patients to prove that the diagnosis has a problem with the baseline data. And this was submitted to British Medical Journal, in which they asked for hospital outcome. And in this case, we decide to analyze the area under the row curve, and this is what you will see. You will see that the baseline PF ratio, using the PF ratio at baseline, give you an area under the rock, almost like a flip in a coin, something that you can guess. I mean, that is give you irreproducible results. However, the PF ratio under standard ventilatory settings with P5 with the 50% oxygen and PF10 was 69, 0.69. So we add more patients. Now this is a publication in 2019 with 1,200 patients, in which this is something very nice, showing here that at the baseline you cannot get what happened with this patient, because 24 hours later, the distribution of those patients are everywhere. In fact, some of them, they have, this is, I'm talking about moderate and severe. Some of them has what is called mild ARDS. So we analyzed this specific cohort of 1,200 patients and give you a very nice view. When you analyze by cutoff of hundreds, it gives you a different cutoff when you decide to do 150. You know, remember the 150 was a PF ratio that was selected in the accuracy study, in the prone study, in the ROSE trial. So the 150 give you a greater threshold to talk about severity. It could be because based on this graph with 1,200 patients, look like the 150 give you that less patients are in the most severe, and by contrary, the mortality rate increased significantly. So based on that graph on the in your right-hand side of the slide, so we decide to do subsets, respiratory subsets, based on the FiO2 150, okay, instead of 100 or 200 or more than 200. And what happened is we decide that maybe 150 improves the prediction of death, and I'm talking about ICU death, compared to the values that we have already in the Berlin definition. We use a derivation cohort of 1,000 patients and a validation cohort. So this is a derivation and validation study. And the threshold were 150, based on 2 levels of PEEP, greater of 10, and I mean, you have 4 subsets, depending on, you have lower than 150, higher than 150, lower than 10, or higher than 10. It's something, the graph is very similar to the Jane Forrester in New England with the acute myocardial infarction, when they did the 4 subsets based on the cardiac index and the pulmonary wedge pressure. And what happened here, we did the 4 subsets based on the PEEP value and the PF ratio 150, and we got the same 4 subsets at the beginning that has nothing. I mean, at the beginning you cannot say anything, and in fact, based on physics, I can tell you that we cannot establish a clear separation between the behavior of the lung based on the PF ratio, on the response of the PO2 with its interactions with PEEP and FiO2. So 24 hours later is so much different. And in fact, when you do a survival curve with 150 as a threshold, you see that the mortality rate of patients, this is why I think the trialist in the accuracy and the prone and the ROSE decide to include patients with 150 was because of that. They knew in advance that the mortality rate was much greater in those with less than 150 PF ratio. However, this is not the whole truth, because PF ratio is just one piece of information, okay? This is a very labile measurement, and there are other factors who intervene in the value of the PO2, not only the FiO2 and PEEP, but the cardiac output, the metabolic rate, and the way the ventilator is set, okay? It's not only and the underlying disease that is causing ARDS. In fact, when the solution, we don't think the solution is a PF ratio, is to have the PF ratio as a goddess here of how we define ARDS or define the severity and stratify patients on ARDS. I think we published in 2021 another paper that is called the SPIRE score, and I think that in addition to the PF ratio, we have the age, we have the plateau, and we have the organ failure. The same thing that Adrienne Randolph did with the kids, we found another factors that are associated with mortality. And in fact, you see that the area under the curve is no change. It doesn't matter how many patients you have about the accuracy of prediction, but compared to the score that is 0.86. And now, because I heard in this meeting bells about how to modify the ARDS definition, I would like to introduce a 3-sentence to think about it as a reflection at the end of this talk. One is by Einstein. He said everything should be made as simple as possible, but not simpler. The late Daniel Schuster, he died in 2007, and he published in Chest 1995 there is no data that link a particular PF ratio to predictable structural changes in the alveolar capillary membrane. And then in a recent paper by Alicia Rizzo and Taylor Thompson is one of the authors. This is why I put his picture. He said large observational studies are necessary to discern a specific injury mechanism that are responsible for ARDS heterogeneity. Thank you. I hope you don't mind that I put that picture.
Oh, no, not at all. Just was so well done. Thank you so much. One other footnote, Jesus, to the Rose trial, which indeed we picked the 150, is a large measure because of your work, and we're committing to a patient now to 48 hours of neuromuscular blockade. We're trying to confirm the ACURAS trial. We knew that some of these patients on the higher PEEP approach were going to no longer meet this criteria. So there was an early exit criteria for that subset that you've identified that are PEEP responsive, tremendously PEEP responsive, and allowed them to come off neuromuscular blockade. And it's a large measure because of that work.
Yeah, I think well, this is what I think. A prompt recovery of patients coined as ARDS contradicts the natural history of ARDS.
Yeah.
I mean, I have seen patients, well, I have seen some of these CRF admitted and treated by some people who participate in this meeting, in this, in this cohorts, in these studies, that a patient in 36 hours diagnosed as a moderate and severe ARDS, they are extubated. They don't have ARDS. Yep. They look like they have ARDS, but they don't have ARDS.
Yeah,
Exactly.
And just to add to that, you know, your figures about how the PF ratio can improve very rapidly. If you remember, actually, one of the inclusion criteria for the Rose trial was that they still had to be met the PF criteria of less than 150 from the time when you screened them to like 6 hours after when you randomize them, because there were subsets of patients that from the time that you screen and met the criteria,
They improve.
they improved enough that they no longer met the criteria. And we didn't enroll those patients specifically because of what you have shown.
You're right.
Yep. No, exactly right. So we've been hogging up the Dr. Villar. So anyone else like to ask him a question?
Well, I would like to say something because a friend of mine is here. The editor of the journal when the paper was published, was accepted by the reviewers, was Massimo Antonelli.
And he is here.
And he was very happy.
I'm biased.
I'm biased.
You
And
are
he was
not
very
a
happy that
biased-
the paper was accepted.
Dr. Antonelli is a scientist. He doesn't have bias.
Not true. I'm a human being.
Bravo. Yes, please.
Thank you for this nice presentation. I'm Luigi Vetrugno for Chieti Italy. I have a question for you or for all the presenter. I talk about PF ratio and mortality. So, what do you think for the next definition of ARDS about lung ultrasound and morphology? Because you know that in this room, 3 of 10 have a PFO open. So PF ratio could be...
Let me see. I think one of the criteria.
Thank
I
you.
mean, I am not the expert who is going to have a final words, but I like very much the idea because I was thinking a lot of time because I have seen patients with trauma traumatic ARDS with unilateral disease. So when I heard, Adrienne, that the pediatricians decide to have unilateral disease, I was saying like this, yes, because maybe in the future, the definition should be modified to include unilateral under certain circumstances. The second is that we, in the beginning, was only X-ray. Now we have X-ray and CT scan. So eventually will be not only lung ultrasound, will be any technique that define the image of the bilateral or diffuse, what is no bilateral diffuse infiltrates, at least in one lung. The PF ratio, well, maybe as in the next definition or in the next update of the definition, you have to challenge that the PF ratio at baseline give you irreproducible results to do any randomized control trials. And the PF ratio should be mandatory for me. It's mandatory to wait a few hours. When I say a few hours, I know in the Rose trial, the median was 8, but there are some patients who stay longer. But it may be 12 hours. I don't know. But for sure, a baseline is useless.
We can take another.
Yeah, I just wanted to comment, is it time to bring back the diagnosis of acute lung injury to, is it time to bring back the diagnosis of acute lung injury to describe those people with better PF ratios and perhaps more rapid clinical improvement?
Well, it's a new terminology now that is acute hypoxemic respiratory failure. That include what you said, the two sides of the balance. But I don't know. This is something to be discussed. But certainly many patients with coined as acute hypoxemic respiratory failure, they had ARDS. And in fact, during the COVID experience, we learned, for me, I laugh a lot. I mean, when I say it's a joke, when they said that in the Berlin definition, you need to have 7 days or lower to have, to have ARDS. When in COVID, especially in COVID, patients with less than 7 days, any treatment does not give you any insight, any prediction of anything. And in fact, the dexamethasone doesn't work in patients with less than 7 days after the onset of the symptoms. So, I don't know.
Yeah,
I will tell you.
It's such a good question. The Berlin, with all of its flaws, did validate at least its prognostic validity in the Lung Safe global registry, and the mortality of the mild subset that we might go back and call ALI is still 22%. So we're a group that calls something mild that kills 1 in 5. And it's a big public health concern. So whatever we call it, I don't know, but we still need, and your PF over 150 had a 25% 28-day mortality. So that's a group we can't abandon. What we call them, I don't think is so important. So
yeah. Those trials require thousands of patients just to prove.
They do. It's very important to know the effect size is going to be is lower. Yeah. Jesus, thank you so much.
Thank you.
All right. And now we'll head on to the second part of the presentations today. And I welcome to the stage Dr. Lieuwe Bos from Netherlands. Yeah, there you go. And he will be speaking to us, right? He'll be speaking to us today about ARDS subphenotypes, lessons from COVID-19. Thank you, Dr. Bos.
Thank you very much. All right, so lessons from COVID-19, a very hard subject to talk about. ARDS subphenotypes are very easy to understand, so at least that part I'm going to focus on. This is my team. Some of them are present here in the room. They are the most remarkable, awesome team of PhD students and postdocs in the world. So all the credits for everything in my presentation go to them, not to me. So these slides are a bit weird because they should be in the format of a 16:9, but they are on a 4:3, but it doesn't matter. So what I want you to remember from today is 4 points. We need to define what we consider to be a subphenotype. Pharmacological treatments can work in one subphenotype of critically ill patients. If we dig deeper, additional subphenotypes can always be found, and time-dependent effects are understudied but really important. If you remember those 4 things, you can doze off now and still get a good message from this presentation. So what do we consider to be a subphenotype? I think one of the main lessons I learned from COVID-19 is that apparently everyone can make up a subphenotype based on a couple of patients, and within a year we had about 150 to 100 subphenotypes, which led us to write a paper to sort of describe what is premature and what is responsible. And those choice of words is on purpose. I think we need to be much more responsible in what we put out into the world. And there are a couple of things I'm going to focus on in what I think is more responsible. So first, we need a definition. So in this paper with Lorraine Ware, we try to go from the phenotype that we have, which is ARDS in our case, a set of readily observable characteristics that we might need to refine, but sort of outline the broader strokes of this syndrome. We can always go to a subgroup. We can just take a continuous variable, cut the population in 2, somewhere in the middle, maybe use the median of the mean, and then we have 2 nice populations. The big problem there is if you take a new population, those values will be slightly differently distributed, and patients might have shifted categories. Or, as alluded to in the previous presentation, if you re-observe the same patient a few hours later, they may have shifted categories. Of course, that is very, very bad if we want to talk about consistent states and randomize patients to certain treatments based on their subphenotype. So subphenotype should be a little bit more multidimensional, a bit more consistent, and it has discrete categories. And an endotype in the end, where is something where we know the mechanism that we can target with the treatment. So it's sort of a pyramid where we start at the bottom and you just take any subgroup. And you can do this thousands of times, even in one trial. So it's really a broad category. And if we move up the pyramid, per definition, it will get smaller and smaller and smaller. And there might be just a few relevant subphenotypes at the top that we can actually target with treatments. So we're currently here, right? We don't have a good endotype for ARDS. And I think this was a very telling paper in JAMA from the group of Chris Seymour. Is it phenotype anarchy at the moment? We need biological plausibility. We need to identify these things. They need to be non-synonymous, reproducible, and treatment responsive. Okay, so that's the first point. I'm going to move to the second one. Pharmacological treatments can work if we focus on one subphenotype of critical illness. This is an excellent review article on the biological changes seen in patients with COVID-19. Published in 2022, but mainly based on studies from 2020. And what's convincing is that if we map the treatments that had at least one positive randomized controlled trial, we can see that we have successfully targeted patients with COVID-19 on several points. C5 inhibitors might or might not work, but at least one study was positive. JAK-STAT and IL-6 receptor inhibitors were positive in multiple studies. Imatinib and heparin in specific populations of moderately ill patients. But we have to remember that these patients had much less variation in inflammatory markers than our typical ARDS population. In this fantastic article from Daniel Eisman he summarized the evidence only in 2020 and came to the conclusion that most of these patients with COVID-19 had cytokine IL-6 levels that were close to the detection limit and did not resemble patients with ARDS or with cytokine release syndrome at all. If we look on that axis, and this is data from a cohort I'm going to show more about, it only goes up to like 100 nanograms per milliliter. So it's very, very, very low concentrations, and some of the patients are in the ranges of the healthy controls depicted here by the dotted line. But of course, even within that variation, so remember this is like 1,000-fold less variation that we normally see in critically ill patients, even within that variation, we can still find subphenotypes. So I'm going to talk to you about a randomized controlled trial of COVID-19 patients treated with oral imatinib or placebo and with an outcome of 90-day mortality. In this study, we used baseline biomarker data. So we were not going to look at clinical data or anything that was readily observable by the physician and might have influenced their treatment decisions, but only things that were measured in hindsight and would never influence any treatment. And we found, using this data from patients on the ward, 3 subphenotypes. So one could argue again, this is just another subphenotyping scheme. It does not have any relevant implications. And that might be right, and I might agree with that. So we need to look further. If you look at these 3 groups, you might appreciate that in yellow, cluster 1, and in orange, cluster 3, had higher levels of TNF receptor 1, classically a biomarker of the hyperinflammatory phenotype. But they were discriminated by a difference in surfactant protein D, a biomarker of epithelial injury in the lung, with the 3rd orange phenotype having much higher values than the cluster 1 in yellow. We then evaluated the treatment effect of imatinib within these 3 subpopulations in the cohort. So the second cluster, let's focus on that first, with the green header, had a very low mortality. These patients were probably never going to be helped. They frequently died because of comorbidities that had little to do with COVID-19. Cluster 1, in yellow, there was no treatment effect of imatinib whatsoever. The treatment effect was only observed in this cluster 3 that had high epithelial injury in the lung and later was found to have much more pulmonary edema. And the treatment effect of imatinib is thought to be primarily focused on limiting the permeability of the lung by an endothelial protective effect. So that might make sense. So last but not least, time-dependent subphenotypes are understudied. We focus on one observation at baseline, whatever that means, ICU admission. We need to reassess patients at the second time point. And I think the data that was shown by Professor Villar in the previous presentation is an excellent example on how you can reassess patients after a couple of hours and actually learn something. I mean, that's what we do at a bedside every day, right? So, yesterday is but today's memory and tomorrow is today's dream is one of the things I try to think about when analyzing data. And so we should not only focus on these baseline data points. So I'm going to talk about a study from our group that was really inspired by this very strong notion that there were multiple subphenotypes present at baseline in patients with COVID-19 admitted to the intensive care unit. So we wanted to do this responsibly. So we had an observational study of invasively ventilated patients, about 1,000 in the Netherlands, and we had 2 validation cohorts, both from the United States, because I think if you cannot replicate it in another cohort, it's probably not true. We had only invasively ventilated patients. We had 3 times a day respiratory mechanics and gas exchange data. And we used things like 30-day mortality and thromboembolic events as the primary outcomes. And we used a new technique that I had been wanting to use for about 5 years, but never had the data set to use, called time-dependent latent class analysis. And this really needs granular data. So even the time points that we had at this moment were still quite limited. You would even want more frequent sampling in patients in order to do it really well. So these were the patient numbers that I already talked about. So we actually used 3 techniques. On the left side, you see sort of the data structure. So this is how we think about these data sets that are longitudinal. You have time on the x-axis, you have patients on the y-axis, and then you have all the different variables on the z-axis. So it's a sort of 3-dimensional structure instead of a 2-dimensional structure, which you have with cross-sectional data sets. And then you can start to first do cross-sectional subphenotyping. So just take one time point, which is the second cubicle, and evaluate what happens if you input the data and analyze it that way. And I can already tell you, there was no evidence whatsoever that there were subphenotypes that were reproducible and consistent in this data set. We then did longitudinal latent class analysis using all the data from all the patients, modeling all their different trajectories in all these different variables. And, let me see if I can go back. Yeah. And using that method, we were able to separate out 2 groups. One, phenotype 1 and phenotype 2, or whatever you want to call them. And in the colors, you see the different characteristics of these patients over time, with light being the start of ICU, and the darker the line gets, the later the variable is observed. And you might appreciate that at baseline, the patients were still quite similar. The difference between the groups was not that large. Both were around the point 0. And then the patients start to diverge over time, primarily in ventilatory ratio, a marker of dead space, and in mechanical power, a marker of the amount of energy needed to ventilate the lung. So we wanted to dive a bit further into these 2 components of these subphenotypes. So these, we had 2 subphenotypes. There were more thromboembolic events in that it is increasing in this upward trajectory phenotype, but there were borderline significant mortality differences. So we then set out to, instead of using all these variables at the same time, reduce it and just use these mechanical power and ventilatory ratio, and then model the trajectory of just that one variable. It's called group-based trajectory modeling. That was pioneered in the ICU by Siva Bhavani from Emory in this fantastic paper about temperature trajectory in about 10,000 patients. So we did that again, and now we also included PF and compliance as a sort of negative controls, because nothing was going on in these latent class subphenotypes with PF and compliance. So now you can appreciate on the right side that trajectories and the phenotypes sort of overlapped. The red and the gray lines were on top of each other, and the blue and the green lines were on top of each other, pertaining the same information that we had in this highly complex, very, very difficult to do analysis with time-based latent class analysis. You can also appreciate that this was not the case for the variables that were not so informative in the latent class analysis, like compliance and PF ratio. Using these trajectories, we actually found that an upward ventilatory ratio trajectory was independently associated with outcome in all 3 of the cohorts after correcting for SOFA scores, Apache scores, age, and gender. And we did not find an influence of any of the treatments that we gave to these patients on the VR trajectories. In contrast, an upwards trajectory in mechanical power was mainly driven by a high PEEP strategy. So patients who were hospitalized, typically they were admitted to hospitals that adopted a high PEEP FiO2, a low PEEP FiO2 strategy, they typically had this upwards mechanical power trajectory. So I hope I could convince you that these points are important. We really need to define what we are doing, and we need to be very mature about it, try to validate everything that we do, and not only produce new things. We really should focus on pharmacological treatments within one subphenotype instead of just using very diverse populations. And if we dig deeper, we can always find new subphenotypes, and those might still be important. And the time-dependent aspects are currently overlooked, but very, very important. Thank you very much for your attention.
Thank you very much for that, Dr. Bos. We do have a few minutes for questions, if there's anybody in the audience who may have questions. I see a hand back there.
Oh, it's Tony.
Hello there. Interesting, very interesting talk. How do these COVID subphenotypes equate with standard ARDS phenotypes that we've seen in the past?
So I showed two kinds of subphenotypes. The ones in the counter-COVID cohort, the pharmacological study with imatinib, all the patients in that study almost all had hypoinflammatory ARDS if we would use a parsimonious model. Because since the introduction of steroids, we find that less than 5% of our patients would be classified as hyperinflammatory ARDS. As for the time-dependent respiratory phenotypes, I do not know yet. So Dan Filippini, who is here in the room, is going to look at that in a larger population of COVID-19 patients, but we might extend that to our electronic health records and look at ARDS patients without COVID-19 in the future as well. It's difficult to find databases that have such granular data, to be honest. That is our main limitation at the moment.
Any other questions? So I have a question, Lieuwe. Yeah. This is like fantastic work, and it's amazing how robust you've created this field, right? You've set the standards in many ways. But, you know, a lot of these trajectories are based upon patients in which things are happening, you know, we're treating and so forth. And I wonder actually, you know, if you looked at actually patients who may deviate from what you would have expected them from that trajectory that they seem to have been on in the first day or so, and whether that might be an indication of a treatment effect.
Yes, yeah, that's such an excellent question. I think that holds both for the static subphenotypes. So you could say we would expect a patient with hyperinflammatory to move towards hypoinflammatory as part of the normal response. But this might be more important in these dynamic phenotypes. And I must say I'm not comfortable with the level of evidence we have at the moment to start doing these analyses. I'm not even sure what it exactly means to have a certain trajectory, but I know that SIVA, that I quoted in the temperature studies, is doing that for the temperature analysis. And it gets complicated fairly quickly, and you need huge data sets, and I think this is just another shout out to really needing collaborative large data sets, because you're not going to fix this in 1,000 patients. You need like 10,000 or 100,000 in order to make any meaningful inference.
Absolutely.
All right.
All right, great. Thank you very much, Lieuwe. So, are phenotypes important for ARDS? And we're going to hear from Carolyn Calfee about this topic. Carolyn from San Francisco. Thank you, Carolyn, for coming.
Thank you so much, Taylor and Michelle. Great to be here with so many friends, and thank you to Lieuwe for an awesome talk that in many ways sets the stage for a lot of the vocabulary and topics we're going to be covering today. So these are my disclosures, none of which are particularly relevant to the topic. So I don't have to talk too much about what it means to phenotype or subtype ARDS, because Lieuwe has already laid the groundwork here very nicely for that. We're talking here about different ways to split our patients in heterogeneous syndromes into subtypes that may be more homogeneous. And I think there are many different ways to phenotype or subphenotype ARDS, just like there are many different ways to slice an onion. We've talked here today already some about some of the clinically apparent ways that we can do this. And this has been discussed really since ARDS was originally defined back in 1967, right? People have been thinking about some of these ways to split ARDS, direct versus indirect, mild, moderate, severe, persistent versus rapidly resolving, diffuse versus focal, COVID versus typical, and this is not an all-inclusive list. Some of these may be useful, sometimes these are controversial. I would pose to you that I think what we're looking for here is groups that respond differently to treatment, and that I think is why we seek phenotypes to try to find treatment-responsive subsets within our data. I'm just going to focus very briefly on the utility of clinically apparent phenotypes because I actually don't have time to go through this in much detail, but I think we know that direct and indirect ARDS, for example, are often overlapping and may be hard to identify in clinical practice. We know that severity and persistence are actually already helping us at the bedside. We know that proning is beneficial in patients who have a persistent PF ratio less than 150. We know that ECMO is beneficial in our most severe patients. And we could fill a whole afternoon, in fact, I think maybe part of this morning was focused on treatments for COVID-19 ARDS that in many cases don't work in typical ARDS, haven't been tried in typical ARDS, or are of controversial utility in typical ARDS. So in some ways, we're already doing this clinically. I want to focus on one type of clinical phenotyping that I think is particularly noteworthy just because the attempts to study this have really developed a paradigm that I think we should think about applying to other types of phenotyping in our critically ill patients, and that's diffuse versus focal ARDS. And Jean-Michel Constantin and colleagues tested the hypothesis in the live trial that randomizing patients to a personalized strategy that was based on whether they had diffuse or focal ARDS on their chest X-ray or CT would improve outcomes compared to standard care of the patients. And it was you can call it negative or neutral trial with no difference in the overall outcome. But I'm highlighting it here for a couple of reasons. One, because actually when they looked deeper at the data, they found that 20% of the patients had been misclassified as diffuse versus focal. You can see the overall treatment estimate on the left-hand side here, and then on the right-hand side is the treatment effect when they excluded those patients. And you can see that when they did that, the personalized strategy appeared to be actually superior. So I think this makes a couple of points. Number one, this is a really innovative study design, I think, really randomizing to a personalized strategy versus not. Number two, I think this points out the potential for personalized care, but then number three, the real challenge of how do we classify these patients at the bedside. This was a group of experts who really developed this field around diffuse versus focal ARDS, and even they struggled to classify the patients accurately in real time. So how are we going to think about doing this in future clinical trials? All right, so because I don't have much time, I'm going to focus the rest of my talk on latent or hidden phenotypes, phenotypes that emerge from doing the type of multidimensional data analysis that Dr. Bos was referring to in his prior talk, subsets or patterns that appear in the data, in this case, using latent class analysis. We think that perhaps these phenotypes are identifying a treatment-responsive subset, though to be honest, that's a hypothesis that has yet to be prospectively tested. We know that this hyperinflammatory phenotype has been identified now in 8 cohorts and consistently has higher levels of inflammatory biomarkers and worse outcomes. We can see that in secondary analyses of randomized controlled trials, these phenotypes appear to respond differently to mechanical ventilation with high versus low PEEP, to conservative versus liberal fluid status, and to pharmacotherapy with simvastatin. But this is all a hypothesis until it's prospectively tested and confirmed. So how can we do this practically at the bedside? And this is really the downside of these types of latent phenotypes and why they haven't been as much studied is because they're latent. That means they're hidden. They're harder to identify. So are there ways that we can actually try to identify them for testing these hypotheses prospectively? So we've been working on developing biomarker-based models to do this, and this is work that's been led by Pratik Sinha, who's pictured here, who's a junior faculty member at Washington University in St. Louis in the US. And Pratik developed both 3-variable and 4-variable models that you can see on the right-hand side of the screen, consisting of IL-8, bicarbonate, and protein C measurements, plus or minus vasopressors. And when those were compared to the gold standard of phenotype by latent class analysis, this might be a little bit small for you guys to see, but the 3-variable model had an area under the curve of 0.94, and the 4-variable model an area under the curve of 0.95. So actually, we were surprised by how accurate this was, given that it was a relatively small number of biomarkers. It turns out that multiple different models performed quite well. What I'm showing you here is a table that has the top 6 variables that were useful in classifying the phenotypes and the area under the curve in an independent validation held out data set. And you can see that multiple different combinations performed with areas under the curve of 0.9 or better, suggesting, and we did this because we thought, well, gosh, these are going to be hard to develop, these bedside biomarkers, so we don't want to like put all our money on just one combination. We want to provide some other options in case we need to develop different combinations. I'm going to show you just a little bit of data from a study that used this model consisting of IL-6, TNFR1, and bicarbonate to identify the patients in real time. So this study was also led by Dr. Sinha in collaboration with Danny McCauley from Belfast, Tomas Akmani from the UK. A small study, 39 patients with COVID ARDS, but what was done here was to prospectively, in real time, classify the patients to one phenotype or the other, using those models that I showed you that Dr. Sinha had developed, and a novel point of care assay that could measure IL-6 TNFR1 in real time. Bicarbonate was taken from the patient's clinical data, and in real time, this data was entered into a database, the phenotype was calculated, but then the people at the site were kept blinded to that phenotype assignment so that it wouldn't influence their care moving forward or anything else. And we found, much like Lieuwe was implying, this was early in the pandemic, so this was the first wave of COVID in the UK, and even at that point, we found a relatively low prevalence of the hyperinflammatory phenotype in COVID ARDS, consistent with the other data. But it was exciting to us because it demonstrated that, you know, we can start to think about how we would actually do this in real time in a near patient way that could potentially enable stratification into future trials. So what's happening with this now? Well, Dr. McCauley is leading a couple of relevant studies here. So he's leading the FIND study, which is implementing this real-time phenotyping using that same assay in patients with acute hypoxemic respiratory failure plus minus ARDS. They've enrolled about 400 patients so far in the UK and Ireland. And so we hope to have results from that very soon. He's also leading a team of folks that some of us here are involved with, including myself, in a prospective trial proposal called the Panther trial. I'll show you a little bit more about that in a moment, that's aiming to actually incorporate this into a prospective trial design. And then the ICE by COVID network in the US, led by Laura Esserman, Kathleen Liu, and Clark Files, among others, is working to implement real-time phenotyping using a similar strategy among patients at US hospitals with ARDS. Again, right now, this is just testing prospectively, how can we do this? Not basing any treatment on it, but just actually doing it in real time. All right. That's fine if you have one of these devices, but most of us don't have one of these devices. So we've also been trying to figure out how we could potentially use clinical data to try to identify these phenotypes. This is work, again, led by Dr. Sinha in collaboration with Matt Cherpek from University of Wisconsin, applying a type of machine learning model called XGBoost. And what we did in this was to take all of the clinical data that go into the latent class models, put that into this XGBoost model, which is kind of like a fancy iteration of random forest, and develop a classifier. Now, one of the problems with this is it's a black box algorithm, meaning you can't really see what's inside. You can't really understand exactly how the model is working to assign the patients to the different phenotypes. That being said, the model achieved an area under the curve of 0.94 to 0.95 in independent held out clinical trial data sets. And this is real small, sorry you guys can't see this, but 0.88 to 0.92 in observational studies of real world patients, like the type of patients that we might screen to put in a randomized controlled trial, or the type of patients you might treat in your ICU. We then worked, again, led by Pratik here and by Manoj Madali, who did this work when he was an internal medicine resident at UCSF, now a pulmonary fellow at Stanford, to apply this model in the lung-safe cohort. You've heard a little bit already about lung-safe today, the big epidemiologic study, cross-sectional to identify ARDS prevalence. So when we applied the variant of this clinical classifier model in that data set, we found that it nicely separated out two groups, which had very different survival with a hazard ratio of 2.36 for survival if you were in that hyperinflammatory phenotype. And really interestingly, and this was a big surprise, and I think you should take it with a grain of salt because it's not randomized data, but we found what appeared to be evidence of a differential response to PEEP in this study, so that if you were in the hyperinflammatory phenotype and you were in the highest tertile of PEEP, your mortality was lower than if you were in the lowest tertile, and the opposite pattern in the hypoinflammatory group. And that's the same pattern that we had observed in the alveoli trial data set. Now, again, take it with a grain of salt. This was not randomized, and we picked the extremes to try to compare the two. But nevertheless, that's what it is. Uh-oh, slide seems to be stuck. There we go. We have applied this also in COVID-19 ARDS, and this was a collaboration with Dr. Sinha, Dave Furfaro, who's now at BI Deaconess, Dan Brody, and Max O'Donnell from Columbia, where we took the clinical classifier model and applied it to almost 500 patients that the Columbia team enrolled in less than 2 months in March and April of 2020. So if you can just imagine from one medical center, almost 500 patients with ARDS, the type of strain and stress that they were under, a really tremendous effort to enroll these patients. We used the clinical classifier model to identify the phenotypes, and here we did find a smaller proportion of patients in that hyperinflammatory phenotype, but not as small as in later studies. And those patients, everybody had a pretty high mortality, but the hyperinflammatory group was much higher. And again, much to our surprise, we found what appeared to be evidence of a differential treatment response. So these were all patients enrolled before the publication of recovery, before use of corticosteroids was routine, right? About 2/3 of them in both phenotypes got corticosteroids, and we saw that this hyperinflammatory group seemed to have a lower mortality when treated with corticosteroids, not so in the hypoinflammatory group. Again, big red asterisk, steroids not randomly assigned, so there very well may be confounding by indication here. But the steroids were equally administered across the phenotypes. I'll note that in data that I don't have in here and that we haven't published yet, much like Dr. Bos was saying, in our recent cohorts of COVID-19 patients and patients treated with corticosteroids, we can find almost nobody who fits in the hyperinflammatory phenotype. They're almost all hypoinflammatory. So whether that represents changing treatment patterns, changing variants, it's hard to say. But this data is probably relatively unique to early in the pandemic. All right, so as I wrap up here, what are the next steps towards taking this work into clinical trials? Well, I think further prospective validation of the parsimonious model using real-time assays is important, and that's what's happening in the FIND trial and in the ICE by COVID network. Ideally, we'd like to develop an EHR interface to implement the clinical classifier model prospectively, evaluate its stability over time. I totally agree with Dr. Bos that temporal evaluation of phenotypes is really critical, and Dr. Villar has shown us that as well, how important it is to take that into consideration. How does the clinical model's performance change over time? Can we iterate it to make it better as we do that? And then ultimately, I think the goal will be prospective phenotype assignment with stratified randomization and a randomized controlled trial, and that's the design of the Panther trial being led by Dr. McCauley. So the idea here will be that patients with ARDS will be enrolled and using a biomarker-based stratification approach, stratified into hypo versus hyperinflammatory. No treatment will be assigned on that basis, so that's really important. It's really just the same way you would, for example, stratify patients by a lactate level or a PF ratio. It's just another way, it's another dimension of measurement to stratify the patients. And then within those strata, they can be randomized to multiple different interventions and then iteratively evaluate over time whether those interventions are working in both phenotypes, in neither phenotypes, or just in one phenotype. Okay, so in conclusion, I think we're already treating some ARDS phenotypes differently. These are clinically apparent ARDS phenotypes, like more severe and persistent ARDS or COVID versus typical ARDS. New methods for identifying latent molecular phenotypes have been developed, and clinical testing is ongoing to determine whether those approaches have value prospectively, because the real test of all of this work will be whether it makes a difference in prospective clinical trials, and that's really a required step before any of this is implemented for our patients. Thanks very much. I'd be happy to take questions.
As usual, a tour de force. Carolyn.
Oh, thanks, Taylor.
Yeah, an inspiration for young investigators. Carolyn made an observation about latent class and has pursued it. And it obviously has legs, so to speak. There's something there, and now pretty close to prospective testing and clinical trials. Very exciting.
Oh, thanks, Taylor.
Any questions for Carolyn? Maybe I can start with one. One of your early findings, you leveraged the power of randomization in your initial evaluation of the meaning of latent class and found that the hyperinflammatory subtype has a beneficial response to PEEP, but the hypo, it was in the other direction. What is that telling us?
That's a great question, and you'd think since we published that paper now 9 years ago that I would have figured it out by now, but I haven't. So if anybody has ideas, I'd be very open to them. I really don't know, honestly. I have thought about lots of different ideas. I think probably the one that has the most legs is the idea that to me at least, that the hyperinflammatory phenotype is closer to the ARDS that we've been modeling in animal experiments for a long time, and that the hypoinflammatory phenotype is probably not just one phenotype. Actually, it's probably a gamish of a lot of different etiologies and a lot of different biologies all together. And that in those patients, we talked about this a little bit in the roundtable over the weekend, none of the therapies that we implement for our patients are risk-free. Right? All of them have risk, all of them have downside, and so maybe when we aren't applying them in a selected population, we see that downside and we don't really see the upside. That's my best hand-waving answer, but again, we're 9 years in on that observation and I don't know what the actual answer is, so
Yeah,
ideas welcomed.
Yep, no, I share that interpretation. Yes, we have a question.
Do you rely only on serum inflammatory biomarkers, or you also check the inflammatory biomarkers and the bronchoalveolar lavage as well?
Perhaps repeat the question.
Yeah, sure. So the question was, are you relying only on circulating blood biomarkers, or are you also looking at biomarkers in BAL or other compartments? Such a good question. So everything I showed you is using blood biomarkers, but I think we absolutely need to evaluate other compartments. We have some work in progress now looking at tracheal aspirate transcriptomics and metagenomics to see how the host response in the lung compartment and how the pathogens and the microbiome in the lung department may differ between phenotypes. I think there's a lot to be learned from those. The studies that exist so far have been relatively small and have not identified any differences between the phenotypes. We have some, again, unpublished data yet. It's up on medRxiv, though, that suggests that there may be a difference in the transcriptional profile between the phenotypes, with that hyperinflammatory phenotype being characterized more by both innate immune activation as well as Th17 activation. We need to do a lot more in that area. Great question.
Outstanding question. Yes, Lieuwe.
I would like to circle back to the point Taylor made. How do you think there might be overlap between the hyperinflammatory and the non-focal morphologies? And might that explain the different treatment responses? Have you looked at that at all, or are you thinking about doing that?
That's such a great question, Lieuwe, as always. So we have not looked at that exactly. What we have done, and we haven't published this data because we just haven't gotten around to it, but we've compared the RAL score in hyper versus hypoinflammatory patients. So the RAL score is a quantitative way of scoring the chest radiograph that was developed by Lorraine Ware and colleagues at Vanderbilt. And we see that the RAL score is higher, indicating basically more opacities on the chest x-ray, significantly higher in hyper versus hypo, but not dramatically. Like, it's not like we're talking about, orders of magnitude. It is higher, though. The main reason we haven't done it is because the real definition of diffuse versus focal depends on chest CT. And we just don't have a huge database, to your point, of things we need in a large database, a huge database of patients in whom we can really evaluate both the biology and the CT imaging. I would be surprised if there were not some correlation, but I don't know that to be true.
And Lieuwe, you'll be happy to know that Terry Huff and Neil Agrawal and I are working to get all the CTs in rows collected and archived. So that's going to be fun.
That's great, and we're going to have latent class in that data set too.
Yes,
so there we
indeed.
go. There's an opportunity.
All right. Well, Carolyn, thank you so much.
Thank you.
Thank you so much, Carolyn. You really actually created a whole new trajectory in the research in ARDS, so thank you. And it gives me great pleasure to introduce the last speaker of this session, Dr. Massimo Antonelli from Rome, the beautiful city of Rome, who'll be speaking to us on studying the lung microbiome can help.
Thank you, Chair. Unfortunately, I don't have such beautiful and robust data such as those of Carolyn S Calfee or Dr. Bos. But I'll try to introduce something that may add another brick in the wall, and at least can just justify or can explain a little bit how can be the evolution during the ARDS. If you look at the importance of microbiome, in this case, diversity is a plus, whilst the similarities is indeed a minus. When we have no lung injury, we have a distinct microbiome components into the nasal cavity, oral cavity, into the lung, and into our intestine. But as soon as the ARDS appear, very often there is a dysbiosis that is in large part determined by the direct transmission or translocation or even paracrine effect. And this led to a more similar communities. And the final question is, does this dysbiosis in a way or another influence the evolution of the ARDS? If you look at the various elements, you can say that even the endotracheal intubation may change the local components of the microbiome, and the translocation from the gut or from the gut lymph translocation, the use of antibiotics, this regulated response may provoke a context where the evolution of the ARDS is indeed conditioned by the different microbiome and the duration of mechanical ventilation and pneumonia. One important point is just to know that we have two different types of diversity. One is the intra-patient diversity, where you may have two different interpatient diversity. Patients whose components of the microbiome may be different. And then you have the element of the time, where the beta diversity from two different times moment may have a reduction of the diversity, more similarities, and this may not correspond to a beneficial condition, good condition. There are several factors that may contribute to this dysbiosis. The orotracheal per se, for many different reasons. We know that often we use endotracheal tube with subglottic aspiration in order to avoid the inhalation or inadvertent inhalation of small particles of saliva or the upper gastrointestinal tract. We have host factors that may influence the different microbial reproduction and elimination and immigration. And even the environmental factors like the regional lung growth conditions and many others may change this pattern. If we refer to the lung microbiome and ARDS, one of the first studies was conducted on a murine model where was induced an abdominal sepsis through the cecal ligation, and there was the focused on the lung microbiome. And as you can see from the slide, the red column represents the increase of the abdominal species into the lung and the reduction of the diversity between the microbiome of the lung and those of the intestine, with a prevalence of Bacteriales and Bacteroides. Lung microbiota is also related to characteristic of the patient, smoking status, and the evolution of the ARDS may change somehow the relative development of communities inside the lung that has a relative enrichment of Enterobacteriaceae and Provotella and Fusobacterium. But the other point is that the I-alpha diversity, looking at the Shannon index, which is another index for looking at the diversity of this community, microbial community, is maybe diminished in patients affected by ARDS, with some communities that are, on the other hand, prevalent, especially for those who developed a secondary ARDS. And we know also that the respiratory tract dysbiosis may also associated with a worse outcome in patients who are mechanically ventilated. If you look at the alpha diversity, once again, characterized by the different Shannon index and the beta diversity, there are two clusters in these publications where those patients who had dysbiosis had indeed less survival, more mortality rate, as well as less liberation from the mechanical ventilation. If we focus on the COVID-19 ARDS, we have once again some interesting characteristics. For instance, the low commensals, oral commensals may represent an evolving difference, and the overall survival for those who had indeed a higher risk is clear looking at the host transcriptome. It is also interesting to see how in the clinical practices and our interventions may also identify different patterns. If you look at the Shannon diversity and the viral load of the COVID-19, the higher is the viral load and the lower is the Shannon diversity. And this is also related to, in the right part of the slide, to the kind of support we offer to our patient. The diversity is higher for all those patients who receive a lower treatment, oxygen therapy, high flow oxygen therapy, but for those who underwent the ECMO trials, the inhaled nitric oxide, or the end-prone ventilation and mechanical ventilation, the level of diversity diminished consistently. The other point regards also the fact that the increased bacterial burden and fungal burden may interact deeply for the diversity of the microbiome and the development of pro-inflammatory and hypo-inflammatory state, ultimately with the final outcome. If you look at this slide, you can see how there exists a relationship between the bacterial burden or the fungal burden, the amount of mediators in terms of TNF, IL-6, IL-12, and the sparse point represented the various reaction or individual reaction in terms of reduction of the microbiome. The other point is also related to the fact that this lung dysbiosis may also correlate to the mortality rate somehow, and the onset of specific species as complications. And indeed, if you look at what the COVID-19 groups represent in comparison to those who are not COVID, once again, the diversity is consistently diminished, but more interestingly, in a specific subgroup of patients, so COVID-19, we could identify a diversity that was in relation of the anatomical characteristics of the ARDS. Those patients who had indeed a low compliance had indeed an increased amount of bacteriales and protobacteria, whilst those patients who had a low ventilatory ratio and where the pattern was more similar to a microvascular injury, the firmicutes, as here and here and here, were more represented. So apparently, if this signal is a strong signal, it would be replicated in the future. We may also believe that the different contribution of family of bacteria and microbiome may also contribute to the evolution of the ARDS, characterizing specifically a different anatomic pattern. And the graphical representation with the ARDS shows indeed what I've just said to you, focusing on the higher percentage of parenchymal involvement, or where there is indeed a more microvascular component, where, after all, the prevalence for those who had developed a more parenchymal injury had indeed a higher level of bacteroides. The Shannon diversity has been put in relationship with the final outcome, and those who had a lower Shannon diversity were also those patients who were more prone to die respect to the other group, where in a way or another the survival rate was higher. Which are the take-home messages? These are just some spots on an evolving knowledge that doesn't pretend to solve the problems, but probably open a new windows on a universe that is not known enough, especially in the evolution of the ARDS and the possibility of complications. We have seen so many times treating our COVID-19 patient, how often they die not before the COVID-19, but because of the infectious complications often sustained by a bacterial infections into the lung. This was very frequent. And how these changes into the microbiome may have contributed in the evolution of the ARDS is still something that we do not know, may simply hypothesized. But for sure, we know that one of the elements that we have learned to is the crosstalk, the interaction between our gut and the lung, at a situation that where the microbiome may represent also, if not a specific signature, something that can characterize different kind of ARDS. And we have seen that over time, once again, the influence of various factors may change the pattern through time for many different situations, may change the composition of the microbiome, and as well as the final outcome. The real point is, how can we act in preventing these evolutions, or therapeutically better focus on a specific therapy that may help this patient to survive? This is something that absolutely a big question mark, and nobody knows for the moment. We can have a better knowledge for the future, and we do hope that the increasing evidences may compose a very complicated picture that indeed is only in part represented by these findings, and how the complexity of these words has been largely represented by Dr. Calfee and Dr. Bos in their own presentations. Thank you for your attention.
That was impressive, Dr. Antonelli. Thank you very much. I have questions from the audience. Please. And please introduce yourself and where you're from.
Yeah, I'm Letali. I'm from Erasmus Medical Center. I have a maybe a stupid question. It's like an egg and
No
chicken.
question is stupid.
Yeah, like a chicken problem. Who is first? Like you said, like ICU patients, they receive a lot of interventions, like mechanical ventilation or the steroids, and their immune system, no matter the mucous immune system or the innate or the adaptive system, are malfunctioned. So have you corrected your immune status when you find the correlation between the microbiome to the prognosis? Do you make it clear? Or?
Yeah. Indeed, I guess that we have three different patterns. One is the one at the baseline for healthy persons, as I represented in one of my first slides, where the microbiome components are clearly distinct depending upon the district you are looking at. Whilst emerges something that is going wrong, maybe some immunodepression, just the immunodepression generated by any given disease may alter because of the medications that the patient receives, because of the steroids, because of the disease per se, may alter the flora. And finally, we do have the situation where an acute disease such as the ARDS, no matter if it is a secondary or primary ARDS, in both cases when you have an important inflammation and where our intervention contribute to the generation of a new pattern with different microbiome. So it's very difficult to identify which one of these three situations is the prevalent one.
Thanks.
Any other questions? I have a question.
Please.
If you can entertain me. So, you know, we've talked to actually at the round table this a conundrum of which compartment, where to get the samples, because most of the work that we have in terms of subphenotyping has been from the blood, because
Yes,
it's
indeed.
easy. Right? Your samples are BAL, is that correct?
Yes.
Okay, what's your feeling about actually which compartments we need to be looking at with regards to phenotyping and how to reconcile?
Reconciliation is something not very easy. By the way, I guess that the two sampling should go together. You cannot focalize exclusively on the peripheral blood samples, simply because there may be some factors, think about the extrapulmonary ARDS and intra-abdominal sepsis, that may be different in terms of induction of the damage at the pulmonary level. For these reasons, it hasn't been done up to now, but we should try to differentiate if there is a different patterns in terms of mediators or other factors isolated into the BAL or from the periphery, looking at the different phenotype of these patients. It's not easy. It's a long work, and also financially, it's costly. That's the problem. This is one of the considerations that at times we forgot to make. All this marvelous analysis that you have done imply an important cost, financial investment. And at times, this is not sustainable in certain areas of the world. What we should do is just to be as ethical as we can in promoting for those who are disadvantaged with respect to the Western countries all the knowledge we know, but for free.
You're here.
Very wise, very wise.
On that lovely inclusive note, thank you for attending, and thank you, Massimo, for inspirational presentation.